a hospital annex in Otweke, which is one of our rural outreaches, but it's a small outshoot of the Federal Medical Center, and it has every other department we have in Yenegua. Federal Medical Center Yenegua serves as a referral center for Bayelsa State and its neighboring states such as Delta State and Rivers State. It is a 520-bedded hospital with about 25 departments and units, including but not limited to our accident and emergencies, our children emergency ward. We have several medical and surgical wards, the health insurance units, our outpatient clinic, and our laboratory complexes, and a lot more. This is just my introduction, and you can see the picture of my facility. I hope my picture is not this is my facility. This is the entrance to my hospital as you come to Federal Medical Center in Goa. So we started our IPC program when we started. It was
hello, Dr. Uche. Your network seems to be dragging.
Just started from scratch, and I was an phonist, and I came back getting. We're having not. Oh, I don't know. Is it getting better?
Much better now. Thank you.
Is it better? Okay.
Yes, ma'am. Thank you.
Much better.
Okay,
Much
so
better now. Thank you.
Can I go on? Can you hear me?
Yes, please go on.
Yes,
please.
ma. We can hear you.
Yes, ma. We can
Okay.
hear you.
Okay. All right. So
Yes,
we got a number of people to join the IPC team, but unfortunately, after we started defining our objectives clearly, what we wanted to do first. That was to at least create some awareness and sensitization about IPC in the hospital. We wanted to get our IPC policy in place and get our IPC work plan, which we had. We had a work plan, and our work plan.
Maria, slide is not showing. Sorry.
My slide is not showing.
Okay,
Yes.
Uche, you've not shared your slides.
It's not showing.
Amaka, if you have the slide, why don't you share yours?
It might help improve her network as well. We are sharing for her.
Amaka, if you have the backup, can you share it so that she will just speak to it?
Exactly.
I thought we were supposed to also be seeing some Indians here. I've not seen any Indians.
Why are you searching for Indians? They are not the ones presenting.
No,
But
They
they are our sponsors and co-hosts as well.
Okay.
So you'll find them amongst the participants.
Okay.
I've seen one Dr. Enile from India and Okpawoye from India.
Can you hear me? Can you see my slide?
Yes, clear.
Yes.
We can hear you clearly now. We can hear you
I
clearly.
see your slide.
Can you see the slide?
Yes, please.
Yes,
Just
I'm
to know,
sharing.
yeah.
Yes, ma'am.
Okay. All right. So this picked the team, but unfortunately, I had some challenges because a lot of my team members now, the Japa syndrome caught up with most of my team members. And at the end of the day, I was just left with my IPC nurse. So we had to start from the scratch all over again. And even right now, we are still trying to put up our IPC team together. But right now, I have both my IPC nurse and one of my consultants in training right now in the CCAPS training. They are currently doing the intermediate program, and I'm happy that we are picked up again and discussed with the MD of my hospital, and we are putting up a committee. It's in progress, and also our budget is in view. So this was a hospital-wide sensitization. We started with a hospital-wide sensitization. My hospital was gracious enough to give me the platform, and we're able to gather everybody that is from every department in the hospital. We invited somebody for this meeting, for this talk. We just wanted to create a hospital-wide sensitization of there's something called IPC. We have an IPC team, and this is how we function. So we went about it. We had pre-test, post-test. There was a lot of teaching on IPC, demonstration on hand hygiene, cleaning, and all that. We had some games. There were question and answer session, and it was a very, very interactive session, and it was actually an eye-opener for the hospital community as a whole. After that, we now started department by department orientation on IPC. So these are some. I actually started with my nurses. I started with the nursing admin, well, the directors of nursing, the ward charges, and I felt the nurses were our front desks in the hospital. So I started with them. And after that, we started with our newly employed staff, our interns. We've had several sessions with them. Then our laundry staff, because we noticed we had a lot of issues with our laundry. You will see some pictures as I go on, and we also did some training for them. Right now, as I speak to you, we are having our 2025, because every year we do this rotational training for all our departments every year. Just during their own clinical meetings, we go into their clinical meetings and we create a little sensitization on IPC and address some IPC issues. Then we have our IPC ward rounds, where myself and the IPC nurse, we go around and we identify areas of challenges. We look at our waste disposal system. We look at our hand hygiene stations. We look at our practices, how what we do, the cleaning generally. We look at the wards and all that, and we have a checklist that we use for doing that. And at the end of the day, we give feedback to these departments when we go to interact with them to say this and these and these are the things we've noticed, and these and these are where we need improvement, and where we also see good practices, we also commend them, and it has been a win-win situation. We've also had our Hand Hygiene Day celebrations. So there's a slogan we have in our hospital, and it has really helped us. And this slogan is, IPC is not a fault-finding mission. Because most times, once they see us, they think, oh, we've come to tell them this is wrong and that is wrong and you're not doing this right. No, we've tried to alleviate that by telling people, the first thing we say is, IPC is not a fault-finding mission, rather is for quality improvement. So that puts people at ease, and it has made us acceptable in our hospital community. So most times, once they see me, the first thing they will tell me is, Dr. Guche, IPC is not a fault-finding mission. I say, yes, we are not looking for fault. We just want to make our services, we want to improve on what we are doing. And that has also helped us to have a leeway. So these are some pictures that are speaking to our activities. These are several engagements had. That is my IPC nurse there, addressing and demonstrating on hand hygiene, how to perform hand hygiene to some groups, some of our ward charges. These are some of the pictures here. This one was where I was talking to our laundry staff, and talking to them, teaching them about good laundry. Some engagements of our World Hand Hygiene Day, when we're creating sensitization around the hospital community on World Hand Hygiene. This is our A&E. We're demonstrating, myself and my team at that time when we had a full house, we're demonstrating on hand hygiene. This was a place where engaging the patients in our outpatient department on the practice of hand hygiene and how to go about it. So this is my old laundry. When we first started our laundry rounds, this was what we met. We met our laundry staff on the grass, and they just jumble up the clothes. Like if you look at this picture where my cursor is, these are dirty laundry and these are clean. So everything was, it was just a confused state. Anyhow, they were also dealing with private clothes and all that. And when we interacted with them, they've not had any form of training at all. So we had to engage them on a 2-day training of good laundry practices. And this year, when we went back to inspect our laundry, this was what we met. So this is our improved laundry. And in fact, it was so encouraging for me. They now have lines, and this is where they hang their clothes now when they wash them. And the laundry is now well organized. Now, this is where they keep the dirty laundry, where they come when they have dirty, they keep it on, because it's actually a very small space. But we had to come together and put heads together with the staff and say, this small space we have, how do we manage it in such a way that we don't transmit infection here? Both to protect you, the person who is working here, and to protect the laundry you are also dealing with. So a few days before this presentation, I went to the laundry, and this was what I met. And I was quite encouraged to see that we have a new improved laundry with our staff more educated and providing quality service for our laundry. So what have we done thus far? We've had improved hand hygiene stations. We have availability of alcohol-based hand rubs, which was donated to us by an organization, and we've been using those hand rubs. We've been giving it to the various wards as is needed, and teaching people how to use them. Improved waste disposal system, improved laundry services. Then we had some IEC materials, although not adequate, but then we had them and we're able to share them around the hospital. 5 moments for hand hygiene, standard precaution, and on waste disposal also. So what is in view? What are we working towards? We advocacy for an IPC committee. That is where we are at now. We are engaging with our management, and the MD has actually given me a go-ahead to say I should nominate who are the people I think can function in the IPC committee. I should nominate and let him have my nominees, and would brainstorm on it together. Then advocacy for our IPC budget, a dedicated budget for the IPC team and our IPC work. We are still on that. Then appointment of our IPC link nurses, that we have also engaged the DNS on it, and we are still working on it. Departments and unit-specific training, that is ongoing right now. We do it all the time, and we are still on it. Now, one thing we are also working on is we are drafting our IPC policy for the hospital. We already have a draft, and by the grace of God, I hope to send this draft to some experts to review for us, and would take it up from there. And we've had some challenges also. Right now, I am the head of department, so it's not as if my work is purely IPC. We don't have IPC dedicated staff for the hospital, but we know why. The Japa syndrome really affected us, and now the hospital cannot afford to just keep some people just for IPC activities. So for that, we are still hoping that as things improve, we'll be able to achieve IPC dedicated staff for the hospital. In conclusion, There is constant improvement in IPC awareness and practice in FMC Yenegua. Support and acceptance of the IPC team and its activity has been very encouraging from the members of staff and from the hospital community at large. The hospital management has shown commitment, really shown commitment to improving and sustaining IPC standard in the hospital. And this has been really encouraging for us and has helped us to continue doing what we are doing. With that, I want to say thank you for listening.
Thank you so much, Dr. Guche. That was a wonderful presentation. Thank you for enabling us visit FMC and Ogua, the oil states, one of the oil states. And if people are jackpying from there, then what will the rest of us say when you are swimming in oil? That was a wonderful presentation. Thank you so, so much. Please, can
Thank
we
you,
give
Dr.
her
Gemma.
reactions? Can we give her reactions? Can we give her reactions? Annie, can you check if Prof has? I think Professor Lainka, yes, is on the call. So we'll keep our questions for Dr. Guche after Prof session, then we'll take all the questions together. So please, Dr. Guche, we still need you with us for the rest of the presentation.
Yes, I'm here. Yeah.
All right. So it is with great honor I will introduce Professor Adebola Olainka, who is my teacher and my mentor. She's a professor of medical microbiology and an expert in infection prevention and control. She is currently an independent consultant providing support to various countries for emergency preparedness and response. Prior to this, she was the IPC focal point for WHO Nigeria. Sorry, for WHO Nigeria. Can you hear me?
Yes, please.
Prior to
Yes,
this,
ma'am.
she was the
Yes, ma'am.
IPC focal point for WHO Nigeria. Professor Lainka is a board member, an educator, an education committee chair of the Infection Control African Network, which we usually refer to as ICANN. She has supported outbreak responses in several countries within the region in various capacities for Ebola, Marburg, Lassa fever, Mpox, diphtheria, cholera, cyclones, hey, my madam, and COVID. She is a mentor to many infection prevention and control experts in the hub and also in the public health sphere. So I hereby make welcome Professor Adebola Olainka. You have the floor, ma. Dr. Festus, please, can you mute?
Okay, thank you everybody and good afternoon. Apologies, I had an emergency and I needed to drop off. Please, could you allow me to share? I think you have the wrong slides. You have the slides on Mpox. So please allow me to share from here. Thank you. Okay, so I want to confirm that
hMPV we can see.
okay.
You can see slides on hMPV.
We can see, ma.
It's ma.
There's a lag on my side, but I don't know why I'm having this lag.
I don't think this is your first slide.
No, it's not.
Okay.
But I have a lag on my side. I'm hoping.
Or
Okay.
do you send so we share from our end?
Can you see it now?
Yes, we can. We can see your slides
Okay.
now, ma. Mm.
Okay, so thank you and good afternoon, everyone. So we'll be looking at infection prevention and control strategies for the human metapneumovirus in healthcare settings. So I'll be starting with a background about the human metapneumovirus. It's from the family of pneumoviruses. In microbiology, we call it Pneumoviridae family, and it shares similarities with the respiratory syncytial virus. So just from the name pneumo-respiratory, it tells us that this is a disease that affects the respiratory system. So the disease causes upper and lower respiratory disease in people of all ages, especially among young children, older adults, and people with weakened immune systems. It's fairly new because it was recently discovered in 2001. And it may probably have been around us for some time. But of course, if you're not looking for something, you don't find it. And you know, particularly for diagnosis, diagnosis targets specific organisms. But with the broader use of molecular diagnosis, the identification and awareness of hMPV has become more important. And you know, recently it caused an outbreak in China, and everybody was afraid. They thought maybe it was a COVID or something similar to COVID that we were dealing with. So just briefly, these are the symptoms of the human metapneumovirus, and you'll see that many times people will say we have flu. We use the word flu loosely. Flu could be caused by many organisms, and human metapneumovirus could be one of it. So we have things like a runny or a stuffy nose, a cough. Some people could experience shortness of breath, sore throat. Some could wheeze, fever, and then occasionally there could be rash. So these are symptoms which also tend to be seasonal across the world at various periods of time. For places that have the 4 seasons, maybe around winter, they get to have a lot of this. For places that have 2 seasons, maybe these tend to be common more in the dry season, and so it goes on. But when we are talking about infection prevention and control strategies, one of the key things we always want to know is how is this transmitted? Because for infection prevention and control, the mode of transmission helps us to know how to deal with it. And you know, really, when we talk about IPC, we want to break that chain of transmission. So hMPV is likely spread from an infected person to others, either secretions from coughing and sneezing, or by close contact, you know, when you're touching or shaking hands, or you touch objects or surfaces that have the viruses of them, and then touching the mouth, the nose, or the eyes. If you remember how COVID is spread, then you know how hMPV is spread. And if you remember the IPC measures we put in place for COVID, those would really be the same IPC measures and the strategies we'll be using in dealing with hMPV. So just a brief throwback on some of the principles of disease transmission and how things are spread. So we have direct contact. This happens more in some diseases like Ebola, but of course we could also have it with common cold. The picture really looks more at people vomiting. Vomiting may not be common here, but we've got cough and cold. And then if you look at the next picture, it talks about droplet transmission. And for droplet transmission, you're talking about inhaling droplets, especially when you are within, when you're close to the person. And we have the agents that do that, including hMPV. Airborne transmission, hMPV would not fall into airborne transmission classically, except maybe under certain circumstances when aerosol generating procedures, for example, are being performed. Vector transmission does not apply in this state. This is just a general slide telling us about how diseases are spread. So for hMPV, we're looking more at contact and droplets primarily. Now, we always talk about standard precautions when we're talking about how to prevent infection transmission. And so looking at the IPC strategies needed for hMPV, we need the basic level of IPC precautions, which are the standard precautions. And we always say that standard precautions are used for all patients at all times. And these are the minimum prevention measures that need to be used. So standard precautions has some elements, or some people will call them components. And I try to always look at standard precautions like a piece of orange. You know, when you remove the skin of an orange, you have different sections. But all these sections together, they form what is called the orange. So standard precautions are like that. And that's why we have the precaution with an S. So it has elements and it has components. And so we use all of these together as an infection prevention measure or strategy. So we talk about things like hand hygiene, respiratory hygiene or etiquette, the use of personal protective equipment based on a risk assessment, SHAPS management, injection practices, ensuring the patient care equipment is safe for use, cleaning and disinfecting our environment, handling linen and waste management. But for hMPV, we'll probably be looking primarily at the first three: the hand hygiene, respiratory hygiene, and the PPE. So our hands, they are a major tool as healthcare workers, and they also form a key link in the chain of transmission. Either we are giving care, we're handling instruments, medications, and so on. So hand hygiene becomes very critical for us as healthcare workers. It's an extremely important IPC precaution, and it helps in preventing the transmission of pathogens, either as healthcare workers or even as the patient. So we talk about hand hygiene, whether it's for hand washing, whether it's for alcohol hand rub, or even for surgical hand antisepsis. So hand washing is with soap and water, and alcohol hand rub is using the hand sanitizer. So here we do a number of things. When we talk of hand washing particularly, one key thing is that the water needs to run. And here we have some innovations that have been used within our settings to ensure that water runs, even if water is not flowing directly from the tap. You can see in the last one, it's somebody actually pouring that water from a jug to make sure it runs. And we cannot overemphasize this. We always talk about hand washing because we understand it as one of the cornerstones of infection prevention and control. Then the other thing we put emphasis on, particularly as people who work in healthcare settings, are the 5 moments of hand hygiene. And I want to believe that by now, if you had anything with IPC, you should understand this. We talk about performing hand hygiene before you touch a patient, before a clean or an aseptic procedure, after body fluid exposure risk, after touching a patient, and after touching the patient's surroundings. Now, the second element of standard precaution that becomes very important when you're talking of hMPV is respiratory hygiene. Some will call it a cough etiquette or a respiratory etiquette. These two are used interchangeably. So what is this all about? This is a precaution that prevents the transmission of all respiratory infections. And so there are some certain components that are called respiratory hygiene or respiratory etiquette that prevent the transmission of all respiratory infections. And this includes the hMPV, which is in focus today in the health facilities. And these are precautions that need to be established at the first point of contact with patients at the healthcare facility. So if we're talking of good respiratory hygiene or cough etiquette, this should be done right from the OPD or wherever is the first point of contact, because that is where you can actually put in a lot of those measures that will prevent the further transmission of whatever the patient came with. So what are those things that we call respiratory hygiene? The way people cough or sneeze is important. So we talk about covering your nose or your mouth, or your nose and mouth actually many times, because when people cough, it's mouth and nose. When people sneeze, they open their mouth to sneeze, so it's still mouth and nose. So covering the nose and the mouth when the patient coughs or sneezes. So this is something we need to teach our patients. Many people, maybe they're unaware of some of these things, and so people need to be taught respiratory hygiene. So a strategy that will work for us in the health facilities is that as part of the health talks that are given to patients, how to practice respiratory hygiene should be a part of that health talk. And in situations when there is an epidemic of any respiratory illness, whether it's hMPV, it's COVID, it's influenza, or what we don't know, emphasizing a lot on respiratory hygiene becomes critical. And how do people cover the nose and mouth? Either by coughing into the inner elbow, into their shirt, or by using a tissue. Now, if a tissue is used, that tissue needs to be discarded immediately, preferably into a covered bin. And of course, when people are coughing and sneezing, they should just be taught as this basic etiquette of you don't cough into the face of people, you don't sneeze directly, you turn your face away, or if possible, you move away. And of course, after handling any respiratory secretions, people need to wash their hands. So what are those strategies we need to put in place in our health facilities? One, hand hygiene stations are going to be important things, ensuring that there are bins, and of course, if possible, providing tissues. And then the last one, which we'll talk about, is the provision of masks, offering medical masks to people who are actively coughing when they are in the health facility. So for example, in the patient waiting area in our health facilities, you want to ensure that respiratory hygiene and hand hygiene are going together hand in hand. You want to provide masks to patients who have respiratory symptoms. We call this source control. So ensuring that those masks are available at our triage stations and in waiting areas. And then, of course, the distancing, keeping people who have a fever, a cough, or who are sneezing at least 1 meter away from other patients. And this we're talking about right from the entry point into our health facilities and having our waste bins. Then the third part of the standard precaution, which we talked about, is the use of personal protective equipment. We all know what PPE are. Those are those special coverings meant to protect healthcare workers from exposure or contact to infectious agents. And we always talk about using personal protective equipment with a risk assessment. So what do we mean when we talk about a risk assessment? A risk assessment is just that evaluation that a health worker must perform to assess the risk of exposure. And how do you assess your risk of exposure? It will depend on your anticipated action and the anticipated extent of contact with the patient, with the respiratory droplets at this point. And this helps you to select which PPE items you're going to wear based on this assessment. And of course, hand hygiene is always part of it, which should be done for each patient at each time. So we have various examples of PPE just on your screen: the gown, the gloves, the medical mask, the N95 mask, or also known as respirator, or some people call it FFP2, the face shield, and the goggles. So what are those ones that we need for routine care of a patient who is suspected to have hMPV? You're going to need your gown, your medical mask, or also called surgical mask, the goggles or face shield, and gloves. So for routine care, you do not need an N95 and you do not need or an FFP2 because these are transmitted mainly by droplets. So the poster you have really puts 1, 2, 3, 4, 5, those things that are needed for droplet precautions, which is the primary way by which the hMPV is done. Now, because now of facilities, of course, if there's going to be an aerosol generating procedure done, then you want to replace the mask with the N95. But generally for routine, you do not need an N95. The other thing that is important if there is a confirmed hMPV outbreak, for example, is the fact that for all outbreaks, you know that we always talk about being able to triage a patient and or being able to screen, actually, not really triad. And so one of the key things when you're screening, you remember the physical distance of at least 1 meter is maintained between the healthcare worker and the patient. And this should be a standard at our screening stations in our health facilities, the distance and then the appropriate PPE. Now, if it's hMPV, then a mask is needed. Occasionally, based on risk assessment, you might want to add the gloves or the eye protection, but primarily it is the mask that is required, and of course, hand hygiene. Now, depending on management of the patient for many reasons, many patients are managed on an outpatient basis. But if there's an epidemic and there are isolation areas, then you also want to look at what the rules for taking care of the patient in isolation. I think I've talked about this, so I don't spend too much time about the risk assessment before selecting the appropriate PPE. But of course, some key things, these are things that we talked extensively on during COVID, but which I'm just going to mention is that always remember that once your PPE is on and your patient care activities have commenced, you cannot adjust or touch your PPE, especially those ones around your face. And of course, if your PPE becomes contaminated or breached, you immediately leave the patient care area and you take off your PPE correctly. And you know, there are those steps of, you know, that before you start removing your PPE, the first thing is you're performing hand hygiene and doing hand hygiene in between every PPE removal. So for hMPV, these are just standard rules. You take off your PPE correctly and you replace it with new PPE, and then you can go back and attend to the patient. Now, our strategies for IPC include what we call administrative and environmental controls. So what do we mean by administrative and environmental controls? These are really administrative things that include like policies, procedures, trainings, and so on that lessen the threat of an infectious agent. So for hMPV, strategies in our health facilities would be educating our staff, you know, putting in place what procedures should be and say, okay, if we have people with a respiratory infection, even before we confirm whether it's hMPV or not, what will be those procedures that we will put in place? What will be the policy of the hospital for health workers in attending to those hospitals? And then, of course, the training by the IPC team or committee will target all of this. Environmental controls have to do with modifying the features of our physical space. Now, for example, if you have, if maybe your OPD, all patients sit in a corridor, and I see a lot of health facilities that patients wait in the corridors, and then there are no windows in those corridors, so there's no good ventilation. So what are the environmental controls? It could be that anybody who is coughing or sneezing does not sit in that corridor. They sit in a place where there's more aeration. And of course, you are also looking at how closely are they sitting together. So can we put in the 1 meter distancing and so on? So what are some of the administrative precautions that we can put in place for hMPV? The triage station, establishing respiratory infection algorithms and pathways in our health facilities. When we talk about pathways, it's like these people, they sit differently and they are attended to early. And then can we have like isolation spaces or holding spaces where they sit, and then of course ensuring we have hand hygiene stations, we have the waste bins and all of that within our health facilities. This is a reminder about the minimal equipment resources needed for a typical screening area. 2 chairs and a table. We normally put the table in between to establish at that minimal 1 meter distancing. The screening questionnaire, the algorithm, hand hygiene stations, appropriate PPE, infrared thermometer, tissues for respiratory hygiene, waste bins, and so on, and of course the signage. Okay, and so this is my last slide. hMPV is not lethal. Of course, we know that when people have an immune compromised situation, they could actually die from any form of infection, even if usually the infection is self-limiting. Transmission of hMPV requires contact and closeness, and people with hMPV, they can contaminate their hands and environment. So standard precautions really become the standard of practice to keep most people protected. And when we're talking about standard precautions, we're talking about hand hygiene, physical distancing, being aware of the disease and what to do. As health workers, it's important that we understand the basic IPC requirements for respiratory infections. Of course, we should clean our environment because they could get contaminated. The treatment for hMPV is mainly symptomatic, and prevention is still the best medicine. So thank you, and over.
Thank you very much, Prof, for that very and practical presentation. After this, if peradventure ever have an outbreak, we already know what to do to address the situation in our facilities. Please, can we appreciate Prof for her wonderful presentation? Let's see reactions.
Well done, ma.
Well done, ma.
All right.
Well done, Prof.
Reaction.
Well done, Prof. Well done, Prof.
Well done, bro.
Well done, Prof.
Great job.
Well
Great
done,
job.
Prof. It was short and nice.
Okay, thank you. That's why I was wishing we could see the
Well
reaction
done, ma.
themselves.
Well done, ma. Well done, ma.
Well
This is a
done, ma.
wonderful
Well
Thank you,
done, ma.
presentation. We really
Professor.
appreciate for this
Ma.
presentation, ma. We are really adopt a lot of key points. So our facility, I know definitely we are.
Okay, can we have some decorum now?
I
Hello,
hope,
hello,
I hope,
hello,
I hope
hello.
we'll get this
We
live.
had rules. We had rules at the beginning of this presentation. Please let's remember our working rules. Okay. So now we have time for comments, questions. Amy, can you, so you can raise your hand or put your question or comment in the chat box. Between us, we'll see how it can go. Okay, I can see somebody has a question. Abdul Jalil Abdullahi. Yes, you can. You have the floor. And please keep your questions straight to the point.
Okay. Thank you, Ma. Thank you for the presentation. We had a case of Mpox at Federal Teaching Hospital, Katsina. One of the concerns we had was with the linen. Do we discard it, or is there any particular way of, keeping it clean because of fear of spread? So that's just what I wanted to get more clarification upon, because I did not hear much said about laundry. Thank you.
Anyway, I will still, Prof has also responded a lot on Mpox. So I think we can allow her take this question since it's a current something that happened at your facility. But please remember we are talking about what? Human metapneumovirus. Yeah, virus. But still, yeah. So I will take two more or three more questions before we take responses. So I can't see. Yes, I can see Francis Agu. You have the floor, Francis. Francis Agu,
Okay,
can you
okay.
mute?
Yes, I can hear you. I want to know if this human metapneumovirus, if it has been diagnosed in Nigeria, and what are the, how can it be diagnosed? Do we have, facilities or diagnostic equipment to make this diagnosis, or is it just by symptomatic assessment?
Okay,
So
then I
that's my
think
question.
all right. Thank you, Francis. Kabiru Zubair, you can unmute and ask your question.
Appreciate Prof. Wonderful lecture. My own concern is with respect to the clinical features that she listed, that most of the features are almost similar to most of the respiratory viruses that we know about. So I don't know, how is this one different from the others? And just like the last speaker, and how can it be diagnosed in the laboratory? Do you have what it takes? Thank you.
So I think those are the three comments we have for now. So the first wants to know how you manage linen in monkeypox when managing patients. Francis, that's Abdullahi. Francis wants to know how diagnosis is made for hMPV. And Habiru wants to know how we differentiate clinical features since almost all the things that cause flu present in a similar way. So how do we know we are dealing with hMPV? So Prof, can you take this before we take the next batch of questions?
Okay, thank you. So let me start with the question on mpox. Rightfully, mpox, for the people who are infected, they shed a lot of the viruses from their skin. So definitely, whichever bed sheet they've stayed on is heavily contaminated. Now, it would be nice if maybe, especially for isolation facilities where mpox is being taken care of, the idea would be for us to have disposable sheets. But of course, we know that in our setting, this may not be available, nor can it be sustainable. So what I would advise is you can reprocess the sheets. I think what we really need to be careful of, especially because of transmission to healthcare workers, is how the sheet is removed from the bed. Many people, when they remove sheets, they kind of shake it and throw the aerosols in the air. So for mpox, there is a way to carefully roll over the sheet over itself so that you don't generate aerosols. Whoever is handling it must be wearing the appropriate PPE also, including the mask and all of that to protect themselves. And then in the laundry, it can be reprocessed. Of course, soaking in the bleach solution, washing machines, then the hot cycle is used, the UV, the ironing and all of that. If it's hand wash, then it's going to be soaking in the same bleach solution like we do for and then bringing it out thereafter and doing the reprocessing. Regarding whether we have hMPV in Nigeria, I have not seen, I am not sure we have a surveillance system for hMPV, specifically in the country. And tie with how is it diagnosed? It can be diagnosed by PCR, but of course you must have the specific primers. Like I said, you must target it to look for it. Because it's similar to a lot of the upper respiratory tract, upper respiratory infections, or even lower respiratory infections, it might be difficult to diagnose based clinically. But like I said, it's not unlikely that we've had it. People would have called it flu. Some may have thought, oh, maybe it's even COVID. It wasn't COVID and so on. What you're not looking for, you won't find, unfortunately. Like they said for HIV, it doesn't show on the face. The symptoms might mimic other infections. But generally, in terms of IPC, which we're talking about here today, the strategies for all respiratory tract infections in preventing transmission is similar across board. Over.
Thank you very much. Responses, Prof. And I think currently also what is being practiced, there's really no specific treatment option for hMPV. And people feel that what you can't really treat, why are you bothering diagnosing? So there are very few places, few countries. It's usually those countries where you have established surveillance systems for influenza viruses that have diagnostic systems for hMPV, because they want to know what is actually causing the outbreak or in cases. So in many countries, usually do not have diagnosis available, and I think Nigeria currently falls in that category. So, since, as Prof has also mentioned, of transmission, usually the same as from respiratory viruses. So just try and prevent infection occurring by using the relevant IPC measures. Ma, I would like to ask that, considering the fact that they can be spread by droplets and land on surfaces, what's the role of environmental cleaning in preventing infections? Thank you, ma.
Okay, thanks. I actually mentioned this in a summary slide when I talked about appropriate cleaning of the environment. I didn't go into the details, but of course, we talked about ensuring that waste bins are provided in clinics so that patients can discard their used tissue appropriately and all that. And of course, the cleaning of the environment, just like was done for COVID, become important. John, I think you're muted. Huh?
Sorry, ma. I was trying to mute the person who was talking, and I wasn't able to find who it was who was speaking in the background. So I can't. Amaka, can you find anything in the chats? So while Amaka is going through the chats,
yeah, someone is asking about a vaccine currently available. No, none that I know
of. I think in some countries,
antiviral treatment. Well, generally for a lot of viral respiratory infections, it's usually symptomatic relief and then overcoming it. But I don't think there is a specific antiviral treatment. It's mainly symptomatic.
Yes, ma. There's no specific antiviral treatment for hMPV. Just as you mentioned, it's mainly symptomatic management. And vaccines are currently on their way being developed, but there's none that is currently being licensed for use yet. So while we are giving Prof a breathing space and Amaka is searching for questions, I think I would like to take us to Dr. Guche, who gave us a wonderful facility IPC experience improvement sharing. It was wonderful. It brought out, when they say IPC, start where you are. I think our facility actually showcased that. They started where they were and they've made giant strides as regards improvement. I love the fact that they already have a slogan. IPC is what? Not fault finding, but a way to improve the service delivery. So with that, everybody's interested in coming on board with infection prevention and control. Then, as she mentioned, most challenges they have as regards JAPA, which I think is happening countrywide. but somehow, with what she's doing, we can see that she's managing to stay on top of the situation. I also like to commend them that hospital-wide sensitization, where you could see the large crowds that they had. That says a lot about what she's doing. And then the fact that even after doing that, they went they go department by department during departmental meetings to further sensitize the healthcare workers and use that route to ensure they have an annual training for all healthcare workers. And for the fact that they also use a checklist when they do their facility assessments. What is not measured or what is not recorded cannot be improved upon. So the fact that they use a checklist shows that they can know the benchmark and they can know how to improve from the current state or the last assessment they did, which was very obvious when they showed us what the laundry was like before and what it currently is. So that was a very good facility sharing experience. I would like to encourage you to keep up the good work, and please let us learn to take action pictures, because a picture tells a story much better than words can, and it's also evidence. So we would like
So Dr. Shaw,
this one.
Dr. Shaw, did you
Okay.
have something to share?
Okay, let me pause and allow Dr. Shiwande to have the floor. You're welcome, ma.
Well, good afternoon, my LOC chairman and the vice chair of NSIC. That was a beautiful presentation, very down to earth, where we are not expecting anything less than that. And I want to commend this session because I sat here and I can see that we had up to 150 participants, and which is a good way for us to spread this IPC messages. Well, according to her, we don't have the surveillance to detect the metallurgical virus may not be here, but even in Africa. But then the bottom line, and what I would want to just say is our standard precaution, that we should always be alert, that whatever comes. Now to Professor Layinka, I have some few people around me that they have something that looks like chicken pox. I don't know. I know it's self-limiting. I know it's a viral infection. It will eventually go. But how do you differentiate, like the other participant that asked you? Do we have the means to actually pin it down? We just suspect and treat as such. Over and out. Thank you very much.
Okay, ma. So let me just clarify. Are you talking about chickenpox and mpox?
Well, I guess it's chicken pox because it's something very simple. You just have some few pox on their hand, just like the picture you showed to us. Because my neighbor showed me her little baby, just about 1+, has, this spotty thing on the hand, preceded by a fever and all that. Eventually it will go. And I was just saying in my head, well, I think it's chicken pox. But is there a way to actually, from the lab, confirm exactly what it is?
Okay, ma'am. Yes, the lab can differentiate between chickenpox and mpox. And currently, actually, in Nigeria, the Nigeria Center for Disease Control tests for the two. So what they do is they test first for mpox, and then if it's negative, they check for chickenpox. So especially because now we have a global outbreak of mpox, I think it's advisable, even if it's a baby, to do that test, to advise them to do that test.
Yeah.
Okay.
Thank you. Thank you very much.
Okay, Ma, there's another comment or question for you in the chat. Daudo Lawal wants to know whether hMPV could present as severe cases, especially in children, and what is our risk assessment level as a country as it relates to hMPV. Then I see you already answered the person who said whether hMPV. I think it's mixing up hMPV and HPV vaccine. But I think Prof has already answered you in the chats. Then Kabiru is just reiterating that environmental cleaning is part of standard precautions.
Okay, so just to address the issue on the risk assessment, I think we've said this in different forms. I said some things, and Dr. Ejembi also said some things about the fact that yes, we are aware there's human metapneumovirus in the world. Whether we have it or not, we do not know. And I'll also tell you how everybody began to talk about human metapneumovirus. I think I mentioned it a bit in the presentation. I said, there was an alert that China was having a lot of respiratory tract infections. And people began to say, we hope it's not COVID. We hope it's not a new virus and everything. And especially because the COVID pandemic started from that part of the world. So that made and China has a well-developed diagnostic system in their health services. So they went beyond just, people are having an outbreak of flu, to identify what really was causing the cause of the respiratory infection. And you know that with whole genome sequencing, you can always find out what is happening, even if it wasn't one of your targeted diseases. So with that, they were able to detect that this is human metapneumovirus. And if you read the response from the Ministry of the Health Ministry of China. At that time, that was around winter, they had human metapneumovirus, they had influenza, they had quite a number of respiratory illnesses, which was responsible for the high number of respiratory illnesses they had at that time. But of course, we know also the world loves things new. Everybody started shouting, which one is human metapneumovirus? And that's why it really became a big thing. But you notice now that they're getting out of the winter period. We're not hearing about a high number of cases. Now, as to what is the risk assessment in Nigeria, I don't think that risk assessment has been undertaken. And there has been no reason to do a risk assessment. You do that risk assessment when you have verified that maybe you have an outbreak or something, and that is yet to be done. Now, whether children would have a severe form or not, we know normally that the extreme of ages may have a severe form of the disease, the very young and the elderly. And that is because for the very young, their immune system is not fully developed. For the elderly, the immune system is waning. So yes, it is a possibility. It may not always be the standard. But like I said, generally, it could cause an upper respiratory tract. In some cases, it could cause a lower respiratory tract infection. It's generally self-limiting. Treatment is mainly symptomatic. Of course, we know that many things could cause a similar picture. So a diagnosis could, a test could be done. I know we have some sentinel sites in the country where they check for influenza viruses and influenza-like illnesses. So those may be centers that may try to elaborate some of the causes of that. But right now, the country is not testing for it.
Thank you very much, Ma. So please, all of us that are still on the call, if you check the chats, you'll see the feedback link. And this is one avenue where we can also reach out to you and share slides and other information when it comes to our echo sessions. So please try and fill the